My name is Crystal Jimenez, and my case presentation is on asthma. Typical patient presentation. A mother brought her 10-year-old son to the emergency room after he was having trouble breathing and constantly wheezing. Before she had arrived, her son was playing soccer with all of his friends. She was worried because she had no clue that her son was in the middle of an asthma attack, and he had not been diagnosed yet. He was experiencing dyspnea, which is often seen as a shortness of breath, and this can be a very uncomfortable feeling for the patient. Sometimes this can range from mild and temporary to serious and long-lasting. Another symptom he was undergoing was wheezing, and this is a high-pitched sound produced when air is being forced through narrow pathways, and the pitch of this may depend on the distribution of the airways. Some risk factors that can play a role in asthma is family history, viral respiratory infections, allergies, smoking, air pollution, and obesity. Asthma is a obstructive lung disease, which means it is characterized by the airway obstruction that is getting worse with expiration. This means that more force is going to be required to expire a given volume of air, and emptying of the lungs is slowed. Some of the factors that play a role in the etiology of asthma are genetic factors, because it could be a familial disorder, allergies, gastroesophageal reflux, the microbiome, exercise, and early antibiotic use. When we look back at a gastroesophageal reflux, which is also known as GERD, it is an acid reflux that can cause an uncomfortable burning feeling in your chest, and the feeling may even move up to your neck. This happens when your lower esophageal sphincter doesn't close properly and allows for contents from your stomach to rise up. Also looking at early antibiotic use, this can negatively impact the microbiota by messing up the body's bacterial composition, which in turn leads to the risk of childhood allergies. Some of the background on asthma is that it originates from the Greek meaning shortness of breath. It affects more than 300 million people worldwide, and it is the most common chronic disease in childhood in resource-rich countries. In the U.S., it affects about 6.8 million children, and as for adults, it is an estimated 18.7 million cases, and the prevalence of this is shown to be increasing. It is an obstructive lung disease that worsens through expiration, and it is different from a restrictive lung disease because a restrictive lung disease has to do with the decreased compliance of lung tissue. Some of the risk factors that play a role in asthma are deficient in vitamin D, because many studies have suggested that the deficiency in vitamin D may play a role in the severity of symptoms, and this has to do with immunomodulatory and anti-inflammatory properties that help with airway remodeling. Another risk factor is gastrointestinal and the respiratory microbiome. This shows that exposure to high levels of diverse microorganisms in early life can be protective and can also lead to the generation of T helper cells. And T helper cells are one of the most important cells in the immune system because they help activate B cells and create antibodies to help fight off microbes and infections. Another factor is tobacco smoke exposure. This has been shown that smoking during pregnancy increases the risk of childhood asthma and wheezing episodes. An example of this would be an exposure in utero to tobacco smoke, and this can lead to an increased expiratory flow and decreased lung compliance. The risk of asthma also increases with second and third-hand exposure to tobacco smoke exposure. Another risk factor is air pollution. Pollutants that come from vehicles and power generation that typically use fossil fuels have been shown to contribute to asthma through oxidative damage, and this increases inflammation in the airways. And lastly, genetic risk factors. There have been many genes that can be found associated with asthma. Right now, they are looking into 8 genes, and very specifically a loci that has been studied is 17q21 locus, and this locus has been shown to define an early onset of asthma and may modulate respiratory infections. The pathophysiology of asthma starts with the airway epithelial exposure to the antigen, which initiates a response in sensitized individuals. This means that different cells and cellular elements play a role in bronchial mucosa inflammation and hyperresponsiveness of the airways. The immediate early response is known as the antigen being inhaled and exposed to bronchial mucosa, which in turn leads to dendritic cell activation. From here, it activates T helper cells and releases inflammatory cytokines. The plasma cells produce IgE to bind to the surface on mast cells, initiating immediate release and mast cell degranulation. The inflammatory mediators such as histamine are then released, and this causes vasodilation, increased capillary permeability, and bronchial smooth muscle contraction. And eosinophils are released, which actually damage the tissue directly, and this releases neuropeptides and contribute to bronchial constriction. The second phase in the pathophysiology of asthma is called the late asthmatic response. This typically starts 4 to 8 hours after the initial response, and this is when leukotrienes are introduced for prolonged smooth muscle contraction. The damage from eosinophils leads to impaired mucociliary function, leading to an accumulation of mucus and cellular debris. This plays a role in resistance to airflow and decreased flow rates. Intrapleural and alveolar gas pressures increase and the perfusion of alveoli decrease. And the last thing that could happen is tachypnea. Before an asthma attack, a patient is often seen as asymptomatic and all of their tests are normal. But during an asthma attack, a patient may experience chest constriction, wheezing, dyspnea, non-productive coughing, prolonged expiration, tachycardia, and tachypnea. When it comes to diagnosing a patient with asthma, we often look at things like the history of allergies, the recurrent episodes of wheezing, dyspnea, and coughing, the exercise intolerance, the evaluation of arterial blood gases and expiratory flow rates, and we often look for underlying triggers, the documentation of reversible obstruction, and the exclusion of alternative diagnosis. Another important factor is spirometry, which is going to be talked about on the next slide. Spirometry is the preferred method to trying to diagnose a patient with asthma. It is known as the lack of reversibility of obstruction in the setting of acute exasperation. It establishes a diagnosis of asthma and facilitates the assessment of severity, and it also measures the amount of air you're able to breathe in and out, along with the rate of flow. The spirometry uses forced vital capacity, FVC, and forced expiratory volume in 1 second, FEV1, to show results. These results right here are shown to classify asthma severity in children ages 5 to 11. So a mild lung condition is seen as FEV equaling greater than 80%, moderate is 60 to 80% predicted, and severe would be anything under 60%. When it comes to treating a patient with asthma, we first want to avoid allergens and irritants. Another thing we can do is use a peak flow meter and adhere to an action plan. A peak flow meter is a handheld device that measures how well air moves in and out of your lungs. We can turn to anti-inflammatory medications where inhaled corticosteroids. And then in intermittent asthma, inhalers are prescribed using short-acting beta antagonists. And in more severe asthma, beta antagonists can be used, but this is more long-lasting. Lastly, we can turn to immunotherapy, which can reduce asthma and improve sensitivity of lungs. These were the references that I used for my research on asthma. Thank you.